Dr. Chungu, and I'm the president of the Zambia Paediatric Association, ZPA. The role of ZPA is to promote overall child health in Zambia. Now, health is just not the absence of having disease, but ensuring that all the domains of children are optimal. So we'd like children to be in schools that respond to their needs, that mentally stimulate their minds. Would like them to play in communities that foster their development, interrogate their curiosity, and really help them to be the best that they can be. And all over Zambia, be it rural Zambia, urban Zambia, our mandate extends to all kids, and we do this working with other partners such as yourself. So please reach out to us. We have a Facebook page that's buzzing with exciting content, and would like you to just connect with us through Twitter, through the contact details on the screen. And so we work with healthcare professionals, with parents, with communities to ensure that children achieve their fullest and best potential. Enjoy the webinar. Thank you.
Right. So we'll start the ball rolling with Mapani, who is going to discuss the clinical management of asthma.
Good afternoon, colleagues. Thank you very much, Dr. Somwe, for that kind introduction. And I also acknowledge my colleague, Dr. Marsden. So yes, indeed, we are going to talk about the clinical management of asthma as our first presentation. And as I have already been introduced, I'll straight away go to my next slide. And so in discussing the management of asthma, we initially want to give a context of, what asthma is, how common is it, how does it come about, and what are the risk factors. This is important. Actually, information sharing is very important in the clinical management of asthma. And the important person that we have to share this information with is the patient, as well as the caregiver in the context of dealing with children. So we'll spend just a few slides there talking about the context of asthma, what is asthma, and so forth. And then we'll go on to talk about strategies for management, and also just an overview of the medicines that we use for asthma. So I've got here a picture that is that depicts 3 scenarios. On the extreme left, we've got a picture of a normal airway in the lungs. And just to mention the parts, this is the airway. And we've got there the lumen, which is quite wide open, allowing the passage of air in and out of the lung. And you can see here, these are the alveoli. This is where gas exchange happens. And in the lumen of the airway, we've got a thin film of mucus. And that thin film of mucus is very important in that it serves partly as lubrication. It also helps to trap, debris that may find itself in the lungs. And along the airways there, you can see that we've got these spiral, we call them smooth muscles, that line the length of the airways. So this would be what a normal airway would look like. Now, when you've got a patient with asthma, they'll have the same airway, but obviously you can already see this patient, the lumen is narrowed when you compare with that one on the extreme left. And then also depicted here is the increased mucus film there. And also you can see the enlarged epithelial lining of the airway. So already that tells you that there's a problem. And then when you look at the airway on the extreme right, this is the airway of a patient who is asthmatic and has, and what we call an exacerbation or an asthmatic attack. And the difference that you can see here is that the smooth muscles that are lining the airway are quite tight. And then the lining of the airway is quite enlarged or inflamed. and the mucous membrane also is quite thickened. And the net result of all this is constriction or reduced in the lumen of the airway. So this is the hallmark of what asthma is. So, and we shall be talking about all these things that I've mentioned here. So what is asthma? So asthma is a chronic disease of the lungs, or usually because there are parents on the group, when we say chronic, we mean a long-term disease of the lungs. And I would actually go further and say it is a lifelong disease of the lungs. And it is characterized by 4 cardinal features, which include wheezing, shortness of breath, cough, and chest tightness. So these are the common 4 cardinal features of asthma. So these symptoms can either resolve spontaneously or they can resolve in response to medication. Most importantly about asthma is that these symptoms will vary over time and intensity, meaning that they are not the same from day to day, from week to week, as well as even in a day. You may have increased symptoms in the mornings or commonly at night, and when daytime comes, the symptoms will reduce. And also in intensity, you may have extreme wheezing or even shortness of breath in one day, which will, not be the same come tomorrow, come the next week, or even in the same day. And also characteristic of asthma is that there's variable expiratory airflow limitation, meaning we are more concerned about the passage of air in the airways, and for the reason that I've already explained, that the airway lumen is restricted, it's reduced. So there is that airflow limitation. And I think most important to note is that it's the part for expiration, meaning breathing out, that is a problem. And then all these symptoms will usually happen in the context of what we call twitchy airways or airway hyperresponsiveness. And it is important to note that this air twitchiness is genetically determined. So in trying to to define what asthma is, we should also mention that asthma has triggers. And depicted in this picture that is on the screen now, you can see that there are several triggers which range from exercise, pollens from grass or even from trees, bugs in the house. These will range from cockroach droppings or house dust mites, chemical fumes, which can arise from all sorts of things, cleaning agents, and sometimes cold air. We do know that some people who have their asthma triggered during the cold season, but I must be quick to mention that some people actually have exacerbations or flare-ups during the hot season. And then there's fungus spores. Sometimes if, in the corners of the house, the cleaning is not up to date, you may have fungus which is growing, and it may also be a trigger for asthma. And also exposure to tobacco. If you have people in the house who smoke and the children are exposed to tobacco smoke, that also can be a trigger for asthma. Then you have, of course, pollution, and this can be industrial pollution. And of late, what has been found is that, pollution from car fumes is also a danger to people with asthma. And then, of course, emotions, when someone is very angry or very excited, stress in itself can also trigger asthma. and also, if pets are in the house, their droppings, their dandruff, and so forth. All these things, are triggers of asthma. I have depicted this because I also wanted to illustrate that in children, flu and respiratory infections are a common trigger for asthma. So how common is asthma? So asthma affects about 1 to 18% of the world population, with about 10% individuals having what is called, severe asthma. And in Zambia, we have, it ranges between 1 to 4%. And this is mostly talking about asthma that has a doctor's diagnosis. And asthma affects all age groups, mostly starting in childhood, but we have also what we call adult onset asthma. So in spite of what is known about asthma in terms of, standardized care and a lot of things that are known about how asthma comes about, there's still an alarming trend of, increased incidence of asthma. And unfortunately, also morbidity is increasing worldwide. And unfortunately, also, in spite of what is known in terms of, caring for asthma patients, we still have patients who still have persistent symptoms and experience a lot of, life-threatening attacks. And also mortality, unfortunately, still happens. So how does asthma come about? So I've got this picture here, which I'll just try to explain in a way that I hope will be simple to understand. So what happens with asthma is that allergens, pollutants, the things that I alluded to earlier, which triggers of asthma, when they come in contact with the epithelial lining of the airways, they have the potential to cause damage to the epithelium. And when they do that, the allergens, these same pollutants, irritants, pollens, and everything, once the epithelium is damaged, they can gain entry into the lining of the airway. And most of the allergens that we deal with are usually of, they are proteins, but there are some that are glycoproteins. Glycoproteins just means that there's a protein and also a carbohydrate component that is incorporated into the nature of the allergen. So the pollens, the smoke, the fumes, and so forth. So once they gain entry into the epithelium of the airways, they are usually taken up by cells that we call antigen-presenting cells. These are just immune cells that will take up the antigen or the allergen. And this is stimulated by a compound or a cytokine that we call a thymostromal lipopoietin. Don't worry about all those terms. We can just call it a chemical compound that will stimulate this immune cell to take up the allergen. And once that allergen is taken up, digested, it's then presented to other cells of the immune system, which once they detect the presence of that antigen, they'll then transform themselves into, what we call T helper cells. And these T helper cells, they are also cells of the immune system. They'll cause a stimulation of the B cells, and the B cells, these cells also that are involved in the immune system. They will produce what are called immunoglobulin, and in this case, we call them immunoglobulin E. So they are called IgEs. And these IgEs, they will attach themselves to other cells, again cells of the immune system that are called mast cells. They are also, basophils. So this whole cascade of events, is actually meant to protect the individual from this antigen or from this allergen which has found itself in the system. But unfortunately, in people with asthma, there's an exaggeration of all these processes that I've mentioned. And by the time the IgE is being produced and it attaches itself to the mast cell, we then say that the person is sensitized. Sensitized in the sense that the next time the person is exposed to this allergen, the allergen will attach itself to the IgE, which is attached to the mast cell. And this attachment will trigger what we call degranulation, or the release of some chemical compounds that are contained within that mast cell or basophil. And these compounds, when they are released, they are the ones which are responsible for the effects of asthma that we see. And these also have various names which are depicted there, but mostly they are cytokines, chemokines, leukotrienes, prostaglandins, and so forth. So what these compounds will do is they'll cause the bronchospasm, that is, they'll cause those smooth muscles that I alluded to, which are in the airway lining to contract. They'll cause increased mucosal edema and also increased mucus production. All this then works to reduce the lumen of the airway and cause the difficulties in breathing. Now, this slide is important because when we come to talking about management of asthma in terms of the medicines, usually those medicines will target to block, different sections of this cascade. Okay, so it is important to understand this. And once our patients, our caregivers understand this, then we can work together to avoid exposure to these allergens or to these triggers of asthma. I must say that even if it's not mentioned here, even respiratory tract infections are also responsible for damaging the epithelial lining of the airways. So what causes asthma? I think I've already alluded to the fact that there's usually a genetic predisposition, which means asthma therefore will run in families. And it's usually a triad of symptoms that we may find. You may find that the same person has asthma, has eczema or allergic skin rashes, as well as rhinoconjunctivitis, which means they have got itchy nose, itchy eyes, and so forth. So in the causation of asthma, apart from a person being genetically predisposed, there's also environmental factors, which I've already alluded to, exposure to allergens, and so forth. And then there are risk factors which will make such a person even be more likely to develop asthma. And some of the risk factors will range from events that happen in the prenatal period. We know that when there's maternal severe uncontrolled asthma, maternal obesity, a high gestational weight gain, and even, during the prenatal period, if there's exposure to tobacco, that will increase the susceptibility of a child to develop asthma. Then there's also the issue of perinatal factors, and one of the ones which has been or rather one which is mostly talked about is the issue of babies born via cesarean section are at increased risk of development of asthma. And the hypothesis there is that those babies are not exposed to bacteria, the normal bacteria that will be found in the birth canal of the mother. So that in itself will predispose them to developing asthma, later on. I've already alluded to genetics, and the genetic mapping for the genes that will predispose someone to develop asthma have already been mapped, and I won't bother you with all those. And then in the postnatal period, we've already alluded to viral infections, and mostly we are usually concerned about rhinovirus and respiratory syncytial virus. Then there's tobacco smoke exposure, obesity in early infancy. And also what has been found is children who develop food allergies below the age of 4 years will usually be susceptible also to go on to develop asthma, and then obviously air pollution. What has been found also is that breastfeeding is protective in early life in developing asthma, but unfortunately it has been found that for those people who are susceptible, who have the genetic constitution that predisposes them to developing asthma, may not be protected in the long run. So breastfeeding is protective in early life. So what are the clinical features of asthma? I think I've already alluded to them, the 4 cardinal features, which are cough, shortness of breath, chest tightness, and wheezing. What is important to know is that these symptoms may be absent for weeks, months, or even years. And this sometimes causes people to think that their asthma has gone away or they are healed of it. But what we need to know is that these symptoms are there lurking in the background. And also what is important about asthma is that patients experience episodic flare-ups or exacerbations or what are commonly called attacks. The problem is that during flare-ups, these may be life-threatening, and it is during this time, during flare-ups, during attacks, that asthma will cause mortality or will kill patients. So we are very concerned about that. And these flare-ups usually cause significant burden to the patient, family, as well as the health system. Airway hyperresponsiveness and chronic inflammation persists in the absence of symptoms. And this is very important to understand, because even when we come to talk about medical management of asthma, it is important that patients must understand, patients as well as caregivers must understand that even if you do not have symptoms at any particular time, there's always that chronic inflammation going on in the background. And if you do not control the asthma, then you may end up with flare-ups, and that is a big problem. So now, talking about strategies for managing asthma, the 2 main important goals for managing asthma are to optimize control of symptoms, as well as to reduce the risk of asthma exacerbations. So when we talk about optimizing symptom control, what are we talking about? We are saying we want to reduce the intensity and the frequency of troublesome asthma symptoms, because these symptoms, especially for children, they stop them from having a normal life. Not only that, we want the patient to maintain a normal as well as normal or near normal life. And for children, that means the child should be able to go to school, they should be able to participate in sports, they should be able to play. For adults, of course, we are concerned about them being able to go for work. We want to have as few nighttime symptoms as possible. If possible, keep it to less than 2 nights of waking up per month. Minimal need for acute relief of medication, also what we aim to achieve. I'm hearing a noise. I don't know, someone needs to mute themselves. Thank you. So when we are talking about specific goals to optimize symptom control, we are also talking about optimizing lung function. As we may know, children's lung capacity is still growing. So if they are having these recurrent episodes, symptoms which are not controlled, it may impede the growth of their lungs, and therefore their lung function will be reduced. What is also important is to bring on board the caregiver as well as the patient themselves to be a part of managing themselves. So what are the specific goals for reducing the risk? So we want to prevent recurrent exacerbations. We want to reduce the need for patients to have these recurrent exacerbations, which make them go to hospitals, being admitted in an emergency situation. And we also want to prevent reduced lung growth in children, which I've already alluded to. Because if the lung capacity in a child does not grow to its optimum capacity, then as an adult, they will have reduced lung capacity. And then optimization of pharmacotherapy with minimal or no side effects. So what are some of the factors increasing the future risk of asthma? Anyone who has had one or more exacerbation or attack in the past year is usually at risk of having more exacerbations. Poor adherence to asthma medication is also a problem. Incorrect inhaler technique, low lung function, and then being exposed to tobacco smoke or even vaping, because I'm mentioning vaping here, or what is called e-cigarettes is a common thing which is now happening amongst our societies, especially among youths. So that also is a risk for people to develop exacerbations. So what are the essential components of asthma management? Now, having had that overview of what asthma is and all the factors around it, what are the important factors that we need to take into consideration? So there's patient education. Patients, and in the context of children, they need to be educated. What is asthma? How does it come about? What are the triggers? And it is important actually for a patient or caregiver to try and identify what is that thing that triggers this asthma, because part of management is to avoid those triggers where it is possible. And then for those that cannot be, avoided, they have to be controlled. We have to control asthma triggers. Apart from that, then there's the issue of monitoring for changes in symptoms or lung function. And then I've put pharmacological therapy at the end, because before you actually start the patient on asthma treatment, all these things must be taken into consideration. Because, for example, if you start a patient on asthma medication, but the patient is continually being exposed to whatever triggers it, then you are not going to achieve the two important goals. Symptom control will not be optimized, as well as reducing the future risk of exacerbations. So now, talking about pharmacological therapies for asthma, I want to make it very clear that inhalation medicine is the preferred medicine. We have completely moved away from taking asthma medicines orally, whether it's tablets, salbutamol tablets, or even salbutamol therapy. And what I have depicted there, I'm just trying to illustrate that when you give the medicine by inhalation, you are actually delivering the medicine in the airways where all the drama is happening. So you can see there the medicine goes straight away into the airways and into the alveoli there. So medicine for asthma is inhalational medicine, and we must completely move away from taking tablets and so forth. What this facilitates also is, some asthma medicine, like any other medicines, have side effects. So when you deliver the medicine to the airways, you lessen systemic side effects. A lot of patients who take salbutamol tell you that they have palpitations and so forth. So when you deliver the medicine into the airways where it's needed, you reduce on the side effects, as well as it allows us to give very small doses which will be effective in the airways, as opposed to taking orally. The medicine passes through the liver. Some of it even goes to the toe where it's not needed. So inhalation medicine is the preferred medicine for asthma. Asthma medicines will usually act at different points. So the types of medicines that we have, we usually call them, there are usually two types: controller medicines as well as reliever, and we also have combination medicine. But we also have what we call add-on treatments. These are medicines that are usually added onto controller and reliever medication for patients who have asthma that is difficult or severe asthma. So the types of medicines here, I'm just saying the controller medicines primarily reduce airway inflammation, and I've tried to give examples there. Usually in our environment, we use beclomethasone, budesonide, and also long-acting beta agonists. And then the reliever medicines will usually, they are usually used for as needed relief of breakthrough symptoms. And the commonest medicine that we use is salbutamol, or it's also called albuterol. And then there are combination medicines, which we usually combine with reliever and the controller medicine. So patients should not self-medicate. I think that's one important thing. And it is important to forge an alliance between the patient or caregiver with the doctor, so that education can happen. And I think one of the important things that I must mention today is that reliever-only medication is no longer recommended, because I've already mentioned that in the background, even if the patient has no symptoms, there's always that chronic inflammation. So a combination of reliever as well as controller medicine is usually required. I think I'll skip that. I'll skip that as well in the interest of time. In the management of asthma, there's what we call the Asthma Action Plan. This is an important tool for managing asthma. This is a document that is given to a patient, a written document where the doctor or the healthcare worker has written instructions on what the patient should do at home when they realize that their symptoms are going out of control. And I have here depicted the inhalers that we use. There are many types. There are fancy ones as well as the traditional ones that we are used to. And in this picture, I've depicted, because when you are using an inhaler, there's usually a maneuver that you must do, and that sometimes may be difficult for children, especially children who are younger, below 6 years. So we usually use, an instrument that we call a spacer. So it has a place where you can attach the inhaler, as well as a place where you can put it in the mouth. Some spacers have a mask, and you use it that way. So just to conclude, spacers are very important. Actually, even for adults, we recommend that they use spacers, because the maneuver for making sure that the medicine gets into the lungs is difficult. So, but when you use a spacer, it means that you are just breathing normally, and the medicine will find itself in the lungs. Thank you very much for your attention.
Thank you very much, Muntanga. I think I myself was glued to the screen, because your presentation has been so succinct, to the point. And I think this should be used as a lecture for students, because it summarizes a lot of things in just a few minutes. We'll move on quickly to the second presentation by Dr. Marsden.
Thank you, Dr. Somwe. I hope everybody can hear me. So as I was listening to Muntanga's presentation, I realized that there's going to be a lot of repetition. So I'll try and move over the things that she had actually already covered. So I'm going to be concentrating on the asthma prevention and control. And just to say that a lot of this information can be found from the GINA guidelines, which is a global initiative for asthma. And this was from the 2023 GINA guidelines. So we've already been told that asthma is a heterogeneous disease with inception and persistence, and is driven by genetics and interaction between the genetics and the environment. And we're still not fully understood in terms of what really happens. But as Dr. Mapani said, there's some of the important interactions occur in early life, especially in utero. And now there is actually a consensus that there's a window of opportunity that exists during early pregnancy, when environmental factors may influence the development of asthma. So there are multiple environmental factors, both biological, sociological, that may are important in the development of asthma. So if we look at the primary prevention, so there's primary prevention and secondary prevention. And if we look at the factors that are associated in terms of primary prevention, whether they increase or decrease the risk of asthma in children, we'll start with maternal factors. So if we look at maternal factors, as was alluded to earlier, smoking has been consistently associated with early childhood wheezing. And this is a dose response, meaning that the more you smoke, the more that it affects the caliber of the airways in early life. But what as was said to earlier, the smoking outside of the prenatal period only affects asthma development in older children. If we look at maternal diet, currently, the evidence doesn't clearly demonstrate that ingesting specific foods during pregnancy increases the risk of asthma. And I think this is important because especially nowadays, parents get a lot of information from the internet. We know that they might get that this especially with things like, for example, omega-3 supplements, which is quite a thing nowadays for improving the brain of the child, for increasing like awareness in the baby. However, there was a US and a Danish cohort study that showed that maternal intake of allergenic foods such as peanuts, tree nuts, milk, and fish decreased asthma in offspring. That said, additional other studies, which were randomized controlled trials on maternal diet, and this was taking the oily fish, which contains these long chain polyunsaturated fatty acids, which will be like your tuna or your mackerel or your salmon, which is where the omega-3s are also a fad in terms of taking omega-3s in pregnancy, showed no consistent effects on the risk of whether it was wheezing, asthma, atopy in children. So when we're dealing with maternal diet, dietary changes during pregnancy are therefore not recommended for asthma. If we look at maternal obesity in pregnancy, there was an observational study, which was a meta-analysis that showed that maternal obesity and weight gain increased risk for asthma in children. And what they showed was that for each kg per meter squared increase in body mass index, was associated with a 2 to 3% increase in the odds of having childhood asthma. So that said, I think it's very important to say that as a pregnant, for pregnant women, we're not saying that you should be losing weight and in an unguided fashion. You need to be obviously speaking to your healthcare provider. If we look at breastfeeding, so despite many studies reporting the beneficial effects of breastfeeding on asthma prevention, these results are conflicting. So some studies have shown protection, whereas other studies have shown higher rates of asthma and allergy in breastfed children. So if we look at some studies, there was a meta-analysis that showed that exclusive breastfeeding for at least 3 months was associated with lower rates of asthma between the ages of 2 to 5, with the greatest effect being seen in those with parental history of atopy. So in the first few years of life, there's a decrease in episodes of wheezing, but the problem is that we know that in the first few years of life, children tend to wheeze for other reasons as well, especially these viral-induced wheezing episodes. So regardless of any of those effects, it's important to say that breastfeeding should always be encouraged for the other beneficial effects. It might not be that, because some studies have shown that breastfeeding was associated with a higher risk of atopy, whereas others have shown that there wasn't that much of a big effect. Despite all that, I think it's important to always encourage breastfeeding for its other positive effects. If we look at pollutants, so exposure to outdoor pollutants, e.g. living near a main road, has been associated with increased risk of asthma. There was actually a study in 2019 that suggested that there were 4 million new cases that were attributable to exposure to traffic-related air pollution. If we look at inhalant allergens, some studies have found that exposure to pet allergens is associated with increased sensitization and of asthma and wheezing, whereas others have showed decrease. So in terms of allergens, some studies have shown that there was increase, some studies have shown that there was decrease. For children at risk, because the home environment is usually the primary environment for exposure to sensitization, things like dampness, visible mold in the home, that is associated with increased risk of developing asthma. However, overall, there's insufficient data to recommend efforts to either reduce or increase this perinatal or early exposure to these common sensitizing allergens, including PETs, for the prevention of allergies and asthma. If we look at vitamin D, there was a systematic review, and this was a systematic review that looked at cohort, case control, cross-sectional studies, and that concluded that maternal dietary intake of vitamin D was associated with lower risk of wheezing in children. There were two actually randomized controlled studies that compared the use of whether you give a standard dose of or a high dose of vitamin D, following up on the fact that the initial studies were showing that there was a reduced risk of wheezing in children. However, these two randomized controlled trials did not show that the same effect. When they combined the effects of the systematic review and the RTCs, and they looked at these results in a combined fashion, they, however, found that there was a 25% reduction of risk of asthma and recurrent wheeze at ages 0 to 3. So in the early toddler ages, and that the greatest effect was seen from women who maintained their vitamin D levels in the sufficient levels, which is greater than 30 nanograms per mil through delivery. So, however, both these trials showed no effect of vitamin D supplementation on development of asthma and recurrent wheeze when the kids were older. So it was seen in the younger kids, but not in the older kids. When we look at probiotics, and as you know, I think that probiotics are one of the other things that is a rage in people using it for various things, whether if it's preventing colic, preventing diarrhea. So when they looked at that in terms of looking at does that affect the reduction in developing asthma, they found that Azad et al. Found that there was insufficient evidence to recommend probiotics for the prevention of allergic disease. If we look at the microbial effects, there is something called the hygiene hypothesis. And as Dr. Mapani had talked about the T helper 2, it goes to the hygiene hypothesis. And this suggests that human interaction with microbiota may be beneficial in preventing asthma. And this is because if you are exposed to bacteria, viruses, and parasites, it pushes your immune response to the T helper 1 response. Whereas if you are not, it induces the T helper 2 response, which would be the production of the IgE, as was shown by Dr. Mapani earlier. So there is lower risk of asthma among children who are raised on, like, in essence, the hygiene hypothesis is talking about if you're exposed to a lot of dirt, viruses, bacteria, then it's beneficial at protecting you from asthma. And this was also noted when they looked at children raised on farms who had lower risk of asthma compared to children who were raised on land farms. Similarly, children who are in homes with more than 2 dogs had less risk of asthma compared to those who were not. We already spoke about vaginal delivery being protective. Antibiotic use in pregnancy and in infants is associated with development of asthma, and it goes down to the fact that you're using a lot of antibiotics, and the studies have shown that this has been associated with increased risk of getting asthma. With regards to vaccination, there's no evidence that vaccination increases the risk for developing asthma. As was said earlier, things like social environment, stress, that has been shown to increase the risk of asthma. In fact, there was a systematic review and a meta-analysis that was done that showed that maternal distress during pregnancy increased the risk of developing asthma. And that another study which showed that continued maternal distress in children in the early years was equally increased the risk of developing asthma. As was alluded to earlier, obesity, there's been a lot of evidence. There was a meta-analysis that looked at 18 studies that found that overweight or obesity was a risk factor for childhood asthma, particularly in girls. So with all that information of this, what is the take-home message for primary prevention? So based on all these various studies and looking at the grade analysis, when you're looking at grading of the recommendations, and if you remember the grade, from A, B, C to D, the higher when you are looking at A, then there's like more confidence that the effects are true. When you're looking at D, there's less evidence that the effects are true. So there was a grade analysis that was conducted, and it looked at allergic rhinitis and the impact on asthma. And the conclusion in terms of the take-home message is that children should not be exposed to tobacco smoke during pregnancy or after birth. Identification and correction of vitamin D insufficiency in women with asthma who are pregnant or planning pregnancy may reduce the risk of early life wheezing episodes. Vaginal delivery should be encouraged where possible, and the use of broad-spectrum antibiotics during the first year of life should be discouraged. And obviously, breastfeeding should be advised, not just for the prevention of asthma and allergies, but for its obvious positive effects. If we look at secondary prevention, there's been a lot of evidence that therapeutic interventions for secondary prevention of asthma fall into two categories. So pharmacologic treatment, which was already discussed, and I'll be discussing the control of environmental allergens and environmental tobacco and smoke. Especially in like the developed world, you have allergen-specific immunotherapy. This is where they actually identify specific allergens, especially for children with severe asthma who they've identified a specific trigger, and then they do immunotherapy for it. It's quite an intensive treatment, which you do for sometimes 2 to 3 years of immunotherapy. This rather loaded slide just looks at some of the indoor allergens and the recommendations for reducing exposure to these indoor allergens. And I've put a caveat there stating that allergen avoidance is not recommended as a general strategy. And I see a lot of this happening nowadays where, because people can just walk into one of the private labs, they'll say, I want allergy tests. And then they look at the allergy test will contain all these things that are on this screen. They contain dog, cat, it might contain dust mites, cockroach, mold, and even food allergens. And parents will now come with a result saying that these are the things that I'm allergic to. So how do I avoid all these things? So it's very difficult, and a lot of the evidence now states that individually avoiding one of these things is less effective than avoiding a lot more of the things that are in the group. However, that said, as you can see, for example, animal dander, removing house dust mites, buying special filters, it can be quite expensive and costly. And a lot of the times, for example, the special type of filters that you need to be using are not even available in this country. So this needs to be taken with a pinch of salt so that people understand that when sensitization, as was said earlier, does not equal allergy. If you've been sensitized, you're just producing the IgEs. However, if you're having symptoms following exposure, that is allergy. So if we move to control, what is actually meant by control? So when we talk about control, we're talking about the extent to which the manifestations of asthma can be observed in a patient or be reduced or removed by treatment. And it is determined by the interaction between the patient's genetic background, underlying disease process, and the treatment that they are taking, and the environmental and psychosocial factors. So when we talk about asthma control, we're actually talking about two specific domains, and that is symptom control, and then the future risk of adverse outcomes. So these future risk of adverse outcomes include the risk of exacerbations, the risk of persistent airflow limitations, and the risk of medications side effects. So when we talk about airflow limitations, we're actually talking about loss of lung function. So this is usually something that is assessed by doing things like lung function testing. And it is encouraged to do lung function testing at the beginning of asthma treatment and 3 to 6 months thereafter periodically. So to achieve this long-term control, you need to get a good control of your symptoms, maintain normal activity, and we want to reduce the risk of asthma-related deaths and exacerbation. And when you are doing this as healthcare providers, we want to do it in a partnership between the healthcare provider and the patient or the parent in our case. Obviously, the patient when we're dealing with older. I think somebody has got their. Somebody has got.
Can someone mute the microphone, please?
Yes. So I was saying that just like any other chronic disease, there has to be a partnership between the healthcare provider and the patient or the parent. And then you have to do a lot of self-management education, because as healthcare providers, we'll probably see the patient once every 2 or 3 months, meaning that the patient is doing a lot of self-management at home. So how do we actually assess control? There are different tools that can be used. This one is the GINA tool. It's a very easy tool that you just ask the patient about just 4 questions. And then that will help you to look back over the previous 4 weeks, whether the patient is well controlled, partially controlled, or uncontrolled. And that's daytime symptoms more than twice a week, nighttime awakening due to asthma, and short-acting beta agonist reliever use more than twice a week. So as Dr. Mapani said, that nowadays we're not encouraging the use of SABAs because it's been associated with increased morbidity and mortality and exacerbations. And also, if you use a SABA for a long time, you get the receptors where the SABA works, over time, they get desensitized, and then you get poor response to the SABA. So that, and then any limitation to activity due to asthma. So it can help you to say whether the person is well controlled, partially controlled, or uncontrolled. This is for much, much smaller kids, which is in essence similar, except you might want to ask a bit more questions in terms of like their actual activity, whether they're running around, playing less. And then in terms of the use of the SABA, it's less than once a week. This one is, I would say, Dr. Somwe's favorite, which is the asthma control test. It's a very simple tool that you can use to also look at whether a person is well controlled, not well controlled, or poorly controlled. And this is a little form that you can actually give the patient. They answer the questions themselves. This is for obviously the older kids. But if you look at the next one, this is for smaller kids. And this is for kids that are 4 to 11. The first 4 questions, child themselves would answer, and it's easy because it's just like little faces. And then the last 3 questions are questions that the parent would answer. And then on the left-hand side there, you can see there's a guide about whether the child is well controlled, uncontrolled, or poorly controlled. So remember when I said that when you look at control, we look at asthma symptoms, and then we also look at the future risk. The future risk, whether it's risk of, if you're using a lot of SABA, that means that your risk is high. If there's obesity, if your lung functions are low, if you're having more than 1 exacerbation a year, it's a risk. If we look at risks for airflow limitations, then we're looking at things like low birth weight, lack of inhaled steroid use in the treatment, tobacco smoke, and low forced expiratory volume in 1 second. If we look at risks for medication side effects, frequent use of oral corticosteroids. I think it's very important for parents to know that the use of inhaled steroids in low doses has, most patients experience minimal side effects, and it's usually like things like oral thrush or dysphonia. But if you are frequently using oral corticosteroids, then there's a risk of systemic side effects. When we look at lung function does not correlate strongly with asthma symptoms. And this may sound like an oxymoron, but what has been shown is that sometimes patients have a poor perception of their symptoms. So you might find that if you are a person who is more of a sedentary lifestyle, you may report that you're not having bad asthma symptoms, but in actual fact, your lung function is low. So if you have a low, if you do a lung function test and you have a low FEV, especially if the FEV is less than 60%, that identifies patients that are at increased risk of asthma exacerbation, independent of any symptoms. And it is a risk factor for lung decline over time. Some patients may have a normal or near normal FEV. For those patients, if they are very symptomatic, you need to think about other causes of them being symptomatic, being cardiac disease, post-nasal drip, or reflux. When you do a lung function test and you actually see that there's a high bronchodilator response, that's a risk factor for poor control. But when we're thinking about lung function testing, we should always remember that kids under the age of 5 struggle to do a proper lung function. So it's important that we bear that in mind and don't send patients for lung function tests who are 2 or 3 years old. We've had that experience. I think I will move to some of these non-pharmacological strategies we already discussed, which is like reducing cigarette smoking, being quite active in terms of physical activity. And you can see that the great evidence is quite high. Making sure that indoor allergens are avoided, making sure that certain medications that you know can trigger your asthma, these are the non-steroidal anti-inflammatory drugs, are avoided. And then weight reduction is part of the treatment plan, avoiding air pollution, indoor air pollution, avoiding outdoor air pollution, and avoiding chemicals that sometimes, and usually this with food allergies, I know some people think that if you eat certain foods, they can trigger asthma, but it's usually with IgE mediated, almost to the extent of anaphylaxis. That's where you get this. And it has to be clearly shown from doing allergy testing and making sure that that person has a clear, you can clearly see that when they're exposed to this thing, they actually have symptoms. I'm nearly done, Dr. Somwe. I think my point is that for parents and patients, it's important that they are given information, not only in discussing, but not only verbally, but are also given an asthma action plan, as Dr. Mapani said. It's very important to give an educational program that contains the basic explanation of what the factors that influence asthma, and train them on correct inhaler technique. It's actually been shown that up to 60 to 70% of people don't use their inhalers properly. And when you think about the fact that only 20% of your inhaled medication gets into your lung, if you have a poor technique, it's really, really detrimental to your asthma control. And then a written asthma plan. So finally, what's on the screen are the examples of asthma plans. And the one on the right is just from our neighbors, which is from South Africa. This is the Asthma Foundation of South Africa, which if you see, there's a common theme. Green means that you're in the green zone. And this is something that you can give parents to take home with them so they know what to do when they are either in the green zone, when they're in the orange zone, and obviously in the red zone. It just means that you are having you might be having an exacerbation. So if you look on the left, this is one from Australia, same thing, green, orange, and red, just helping parents to know what to use, what medication they're on, what to use when they're having an exacerbation, and what to do when they're having an exacerbation. Thank you. And yeah, back to you, Dr. Somwe.
Thank you very much, Emilia. Thank you so much. Thank you so much to both speakers.
Dr. Somwe, I see that there's a question in the chat. It says, kindly elaborate more on the use of an inhaler and nebulizer. I think it's very important that people understand that. I know, and I've seen this a lot nowadays, it's happening a lot, that healthcare providers are prescribing nebulizers for patients to buy. I'm seeing a lot of this happening nowadays. It's important for people on the call to understand that spacers, so those little tubes that Dr. Mapani showed in terms of a drug delivery device, are just as effective, if not more effective, and this is research supported, that they are just as effective, if not more effective than nebulizers. So if for smaller kids, so for kids who are under 6 especially, we like you to use spacers. And for kids who are especially under 3, it's better to use a spacer which has a mask, because smaller kids cannot put their mouth properly around the mouthpiece. So for in terms of my practice, I hardly ever first of all, I never prescribe nebulizers to parents to take home. We try and encourage them to use the spacer, and because they're being I think prescribed more often, parents think they're superior to a spacer.
I have a question for Dr. Mapani. In terms of prevalence, you said for Zambia the prevalence of asthma is 1 to 4%. Is that in adults, in children, or both combined?
Thank you, Dr. Somwe. I think the studies that I've seen, it's sort of a compound sort of average in both children and adults. I haven't seen any prevalence studies that have specifically said in children. And as I alluded to, these are studies that have focused on a doctor or physician-made diagnosis. And I think, Dr. Somwe, you probably have more information having done those studies yourself. So I think that's what I came across, but you can correct me.
Yeah, so unfortunately, we're still unable to publish, but the physician diagnosis was about, in children, like 13 to 14 years old, it was about 6%. Self-reported was quite high, twice, 12%. Yeah.
Yes, Dr. Somwe, just to add on to that, some years back, many years ago, when I did a study on exercise-induced bronchospasm, where we used the exercise-induced bronchospasm in children as a proxy for asthma, we actually found up to about 12% prevalence.
Exactly.
So,
Exactly.
yeah, we are in the same range. But when I checked the literature of published data, I found a 1 to 4%. And that is mostly just, doctor diagnosed asthma.
Thank you, Dr. Mapani, for that clarification. There's a question here. How long should beclomethasone inhaler be used as a means for prevention of attacks? Dr. Mapani, would you like to answer that one?
Yes, Dr. Somwe. So I think in the lectures that we've given here, we've alluded to the fact that even if a patient has no asthma symptoms, there's still a background, chronic inflammation going on. So as long as the patient has symptoms, beclomethasone should be used. And when we say, even when you don't have symptoms, the current recommendation is that for those patients who are only taking medicine when they have symptoms, the medication should not only include a short-acting beta agonist in terms of salbutamol, but should also include a steroid, which beclomethasone is, because when you just use a SABA, you are just taking care of bronchospasms, and you are not taking care of that chronic inflammation. So I would say there's no limit up to when you should stop. When we are talking about treatment of asthma, we are always using a step up and step down. So if you reach that level where a person is no longer on daily, steroid, but they only need to take when they are in attacks. So whenever they take a SABA, they should also take beclomethasone. I think that's what I can say.
Thank you, Muntanga. Quickly for Emilia, somebody is asking, how do we decide the frequency of inhaled corticosteroid in children less than 3 years? I think lots of kids under 3 tend to wheeze. So how would you advise colleagues on the use of inhaled corticosteroids in that age group?
Okay, so like we said earlier, age group. So the under 3, they tend to wheeze for other reasons other than asthma. So under 3, it's very difficult to make a diagnosis of asthma, because that's the age where you get a lot of viral induced wheezy episodes. Okay, and if you've heard of something called the Asthma Predictive Index, it's something that is used for kids under 3 to kind of predict which of those kids may end up being asthmatic after the age of 5. And normally it's like you use one major factor or 2 minors, and the major factor include if the parent has asthma, if the doctor themselves have diagnosed with eczema, or the sensitization to various air allergens. So if you have one of those or 2 minors, which is if you have food allergies, or if you check the blood eosinophil and it's greater than 4, and there's wheezing outside of colds, because in that age group, viral induced wheezes are quite common. And other reasons for wheezing could be, reflux, gastroesophageal reflux. It could be sometimes the foreign body. So in that age group, if you feel that you have a kid who's having wheezy episodes, and these wheezy episodes are viral induced, and you're not sure whether the viral induced is because they're having repeated episodes of viral induced with a background of possibly they could be asthmatic, and that's why their airways are hyperresponsive, and when they have a viral episode, it's causing them to wheeze, versus a kid who just has one wheezy episode. Maybe that wheezy episode was a bronchiolitis, or maybe that wheezy episode was just a viral induced wheeze, like any of these viruses, whether it's the rhinoviruses, could also cause wheezing. So in this age group, it's difficult, and I think if the episodes are occurring too frequently, let's say they're occurring more than 4 times a year, and you are seeing that there's a possibility that maybe there's a history of atopy in this parent. One of the parents has asthma. It's disturbing the harmony in the home. They're constantly going to the hospital. Sometimes you can actually, in that age group, put the child on a trial of inhaled steroids. So you could put that child, after looking at those factors, and say, okay, let's put this child on a trial and see whether the child may respond or not.
Yes, so when we are talking about children below six years, we usually classify asthma into 2 phenotypes. So there's one group of children who only wheeze when they have flus or when they have viral infections. And then there's another group of children who wheeze when they have flus as well as outside flus. So for these children who wheeze even when they don't have flus, these are the ones that you can consider to put them on steroid. And as Dr. Marsden has said, these are children that you will not only concentrate on the wheeze, but also look at globally. How is the child presenting? Do they have eczema, rhinoconjunctivitis? Do they have that stigmata in the family of allergies? So it is a case-by-case issue, and there's no blanket, statement to say what should be done with these children.
Thank you very much, Dr. Mapani.
Good evening.
Good evening. You can go ahead.
Yeah.
Yes.
Yes, a great presentation, Dr. Mapani and Dr. Marsden. It's been one of those timely ones. Just a clarification, especially for people out there. I just wanted to you to clarify the use of the recommendation in terms of the use of the product which only has salbutamol, and those that come in a combination of probably salbutamol and the steroid. Like, for example, there's a combination which has salbutamol and budesonide. Yeah, just a clarification there. Thank you.
Yeah, I think, Dr. Somwe, you remember when we first saw this on the market, we were infuriated and say, how can they do this? How can they do this, right? And I think it's, I think in the end, we realized that it stems from, so remember what we said, that you try and avoid using the short-acting beta agonists on their own, okay? So if you're constantly using the short-acting beta agonist, like I said earlier, you get desensitization, and then you find that you may need more and more of the beta agonist. You may not get response from using the beta agonist. So I think it stemmed from the fact that if you're going to use a beta agonist, you should also use an ICS at the same time, an inhaled steroid. So if you look at the GINA guidelines on like step 1, whether it's in kids under 5 or over, they're saying that as an alternative, if you don't have the formoterol ICS, so the quick-acting LABA, which is a formoterol, with the ICS, if you don't have that as an alternative, then you can, whenever you give a short-acting beta agonist, you should also give an inhaled steroid, because by using the quick-acting LABA with inhaled steroids, it's been shown to reduce exacerbations and reduce mortality. So I think it probably came from a point of cost, I'm thinking, because the quick-acting, long-acting, the LABA, the quick-acting, long-acting LABA, which is the formoterol, plus ICS, they're quite expensive. So I think that's where this combination came from.
Thank you, Emilia. Just a quick one on the, somebody has raised the concerns regarding growth. natural growth in patients on prolonged inhaled steroids. Is that a concern as well, Dr. Mapani? So is the concern just when one is taking oral steroids, or we should be worried when one has been taking inhaled corticosteroids for a long time?
Yeah, so the issue of growth, linear growth, because of the effect on the growth plate and so forth when you use steroids for a long time. I think in my presentation, I did allude to the reasons why we want to use inhaled steroids. This is all because you are able to deliver a very small dose that will have effect directly into the lungs, as opposed to when you take it orally, and it has that general systemic effect. So when you use, I think so far what studies are saying is that when you use those small doses by inhalation, the effect on linear growth really is very minimal.